Welcome. I'm Dr. Ogan Gurel. You're on Insights in Medicine, presented by InTimeTV. We have another great hour ahead of us with a fabulous guest and a very important topic. Just want to tell you a little bit about Insights in Medicine. Our approach is integrative. We bring together some of the world's top specialists, and we certainly have one of the world's top psychiatrists today, but integrative in the sense that we explore issues from multiple angles, particularly as they relate to the big picture in general medicine and the impact on physicians and obviously patients. And today's topic, the physical medicine implications of severe mental illness, is a very important one. First of all, of the high prevalence of mental illness in the world, but also because there are significant general medical aspects. And to help us understand this important topic, we have a very distinguished guest and a actually close friend of mine, Dr. Peter Weiden. He was my professor when I was a medical student at Columbia, so it's great to see you again.
Yes, Ogan.
And we saw each other at New York. He was at Columbia, and he was on the faculty at Columbia and a professor at Roosevelt Hospital, and then went to SUNY and was professor of psychiatry there. And Dr. Weiden, throughout his illustrious career, is now presently director of the Psychosis program at the University of Illinois, Chicago, and a professor of psychiatry. And it's great to have you.
Well, Ogan, I was thinking, you know, it's been a while since we've talked psychiatry, and before, when you were a student, a lot has changed in the last 20 years.
Great opportunity, yeah.
And I want to share that, actually, with you and the audience, because there's good news and there's bad news, and a lot of it, a primary care provider, an internist can make such a difference in the lives of people with severe mental illness, because the story has changed dramatically since the 1980s. So
yeah, we were talking before, as I mentioned, Dr. Weiden and I go back, but there's been a study, for example, a CDC study, that has indicated that the average lifespan of individuals with severe mental illness is about 25 years less than non-mentally ill patients. Yeah. And that's incredibly significant.
This has been a wake-up call, and I think that I'd like to put this in the context that we've always known that people with severe mental illness have high rates of medical problems, but we were completely floored by very high-level and high-quality epidemiologic work showing that if you have a mental illness, and this was published by the CDC about a year ago, if you suffer from mental illness, you're going to die 25 years earlier than if you didn't have a mental illness. A quarter century of your life will be gone. This is also happening at a time now where, from a psychiatrist's point of view, we have lots of better treatments for people with severe mental illness. So when I was...
Psychiatric.
For the psychiatric part. So I'm seeing in my practice types of recoveries in patients with schizophrenia or bipolar disorder, types of outcomes, psychiatric outcomes, that I've never seen before. People are going back to work. They're having real lives. They're not just professional patients. Yes. Not everyone. These are still severe illnesses. But it's been very encouraging. But then, in my practice, it's terrible to see someone recover from their mental illness and then die when they're 40 or 50. And this is a wake-up call, and this is a wake-up call that all physicians should know about, that if you have a severe mental illness, your life expectancy is 25 years less. I'd like to tell the audience and you about this, and I'd like to discuss reasons why that's the case, because many of the reasons are preventable, are addressable. It doesn't have to be that. And the data, the understanding has changed. So I want to really go over that.
No, it's a very important topic, and to some extent, we'll explore some of those reasons, but to some extent, and the reasons will be sobering, I imagine, but certainly some of them we can fix and address, but to some extent, this new realization, as you indicated, is a result of the success of psychiatric treatments.
Yes, because 20 or 30 years ago, by far and away the largest killer of people with bipolar disorder or schizophrenia was suicide or accidental death.
Right.
So schizophrenia, people would have a 10% chance of dying by suicide, terrible, usually early in their illness. That was what we were focused on. Now, it winds up that suicide is still a problem.
Right.
But the suicide rates have gone down because the treatments have been getting better. But when we analyze why is there 25 years of lost life, it winds up that it's not predominantly because of suicide. It's because of what are called, quote-unquote, natural causes of death.
Premature, though.
Yeah, premature. So
okay.
Cardiac disease, respiratory disease, cancer, stroke, the killers of the general population, diabetes. So the so-called natural causes of death is what is killing these patients with severe mental illness, but are killing them at much higher rates. So if you look at the rates of heart attacks, of death in mentally ill populations, they're about double that of the general population. So the things that are killing this population are going to be the things that a primary care physician is treating: hypertension, diabetes, hyperlipidemia, cancer monitoring, those sorts of things. That's the main driver these days.
So let's go into some of the causes for this increased risk, if you will. What are, we had categorized, you can categorize them in terms of patient risk factors. Obviously, there's always been an issue of access to health care, the quality of the health care, and then the actual medical implications of the psychiatric therapy. First, what about the patient risk factors?
Well, Ogan, you say that very well, because there are a lot of issues about having a mental illness that then will make it harder for you to get the medical care you need. And we all know that in the general population, it's not like the general population is so great at getting their weight down or their hypertension controlled. But if you have a mental illness, you may have more trouble going to the doctor. You may be depressed or may have trouble with motivation, so you're not going to get to the doctor. You may not follow through as much. That might be one set of risk factors. Another set of risk factors is that you may be stigmatized, you may not care as much, so that there are lots of different reasons. Some old studies from the 1950s and 60s show that if you have schizophrenia, you're much less likely to report having pain from having a heart attack. Or just like someone with diabetes may not report chest pain from having a heart attack, someone with schizophrenia may also have perceptual deficits, so they may not report chest pain, or they may not report an acute abdomen. So they don't report everything. They may not come to the doctor as often. So that there are those sorts of challenges in getting people the access to care that they need with a mental illness. Now, again, in my career now in the last 20, 25 years, that's still a problem. It's gotten a little better as we are getting better psychiatric treatments. Patients are better enough so that they can call and make an appointment to a greater or lesser extent.
Well, it's fascinating that you mentioned about the perceptual aspects of the reporting of symptoms and so forth. We're going to get back to that on the break. Just before the break, I just wanted to show you Dr. Weiden had written an article in the Psychiatric Clinics of North America that relates specifically to the complex disease but also complex care, and clearly one of the leaders in that area. I'm Dr. Ogan Gurel. This is Insights in Medicine. We'll be back shortly.
Come here. Let's see how this looks.
Hey, how's my little horse?
She's a lion.
Yes, she is.
You don't have to be perfect to be a perfect parent. When you adopt a child from foster care, just being there makes all the difference.
Come on! This way! Who is that guy? I don't know! Hurry up! He's right behind us! I know! Come on, get up!
70 years ago.
Think history is a little scary? Then log on to loc.gov and see how much fun it can be. The Library of Congress at loc.gov.
Welcome back. I'm Dr. Ogan Gurel. You're watching Insights in Medicine, the talk show program on InTimeTV. Our distinguished guest, Dr. Peter Weiden, director of the Psychosis program at the University of Illinois, Chicago. Just before the break, I had showed you one of his articles. He is a leading expert in what we would call, what you've told me, is kind of the combination of public health and psychiatry, and how public health influences psychiatry, and how psychopharmacology. Yeah. We'll go into that later in the show. We're focused on some of the physical medicine, the general medicine implications of severe mental illness. And in that regard, I also want to show you another article about a roadmap. This is in the Journal of Clinical Psychiatry, volume 68 of 2007. So it talks about a roadmap for psychopharmacology, obviously geared more for professional psychiatrists. But I think the point is that what we're talking about today is about the general medicine implications.
I think there's a lot, even in you don't have to be an absolute technician or a psychopharm wonk or nerd. If we can cover some of the big picture, I think that can help our colleagues understand what they're dealing with when someone with a mental illness goes into their office, or also when someone with a family member who has a mental illness asks the doctor, you know, my son is on this medicine, what do I do? Or I hope that we can share and learn some things together with that.
Yeah, so just before the break, we were talking about patient risk factors, and it was fascinating you mentioned that some schizophrenics don't report their symptoms. In some sense, again, I'm not a professional psychiatrist, but you learn that schizophrenia to some extent is a mismatch with reality, and it's almost a subtle expression, representation of catatonia and so forth.
Well, I think many primary care providers are worried that they're going to get a patient with schizophrenia or bipolar and just be overwhelmed with kvetching or complaints and so on and so forth. And
actually the opposite.
And while that may happen time to time, the actual problem with schizophrenia is underreporting, not overreporting. When someone with schizophrenia complains of a new health problem, the chances are they should have done it way before. Another thing is that even if someone has psychiatric symptoms, everyone has to die from something. And one important question to ask either the patient or the family is this part of the person's usual pattern of symptoms, or is this different? And if they say it's different and it seems physical, that should be taken seriously. But my main point is that these patients are high-risk medical patients. Someone walks in the door who has a diagnosis of a severe mental illness. This person should automatically be categorized as someone who has a high risk of having an undiagnosed medical problem or undertreated. And the chances are there'll be something there that hasn't been diagnosed.
And from just looking at it again, big picture, from a clinical symptomatology perspective, to some extent, reported symptoms by individuals, patients with severe mental illness, are more significant.
Absolutely, absolutely.
Because of the underlying higher risk factor,
yes,
which we'll get to shortly, but also because of this interesting perceptual issue with their underreporting.
Yeah.
Let's talk a little bit now about access. There's challenges. We'll spend a little time on access to health care.
Yeah.
General health care. Tell us a little bit about that.
Well, people with severe mental illness do not, often do not win the solid citizen, quote-unquote, easy patient. They may not come on time. They may need extra reminders. They may be disheveled. They may smell bad. I can tell you, if I had a private practice with a waiting room, I might be concerned about sort of a shared stigma of someone with mental illness. So I think these are real issues, and I don't want to just put it on the primary care practitioner that there's some very understandable reasons why it's harder to treat these patients. And they can be more of a problem, especially in terms of no-shows or time taken.
Right.
But they certainly need your help. They need our help, and there is plenty that one can do to really help the trajectory of someone's medical well-being, which we'll get to.
Right. The flip side to this, to some extent, is that psychiatrists have very much encouraged general practitioners primary care doctors to look at some of the psychiatric aspects of their patients, depression. And to some extent, access to primary health care is also, I understand it's a controversial point.
Well, I think you caught me here. This is a little bit of do as I say, not as I do. And maybe I can paraphrase, I think that in terms of the collective responsibility of the psychiatric field,
yes,
that often psychiatrists have been encouraging, I think appropriately, for primary care practitioners to diagnose depression in their population, and under recognition of depression, under treatment of depression. Well, you know, there's a flip side to this, and that is that many psychiatrists are, in essence, the primary care provider for people with schizophrenia. And then for that psychiatrist or that system to sort of wash their hands and say, oh, I don't do hypertension, I don't do dyslipidemia, I think there could be some concern about a bit of a double standard here. Now, on an individual basis, what I would say, some psychiatrists who treat the mentally ill are very comfortable treating the medical comorbidities of hypertension, diabetes. Others are not. Or a third group is going to be comfortable with the guidance of a primary care provider. What certainly needs to be done is to enhance communication between the medical physician, the medical care provider, and the psychiatrist. And then who does the prescribing or evaluating? That's, you know, it's an area of flux, but I think I have to be very careful before, because I think we as psychiatrists need to take more responsibility in monitoring the health of our patients as well.
Well, I guess one of the takeaways, and to some extent what this particular show is about, one of the takeaways is just to recognize that interconnection between the primary care and the psychiatry, and recognize the need for communication.
And the takeaway I would say is if someone with a mental illness walks into your door, or if someone asks you about this as a consultation, and let's say you're not a psychiatrist, you're a specialist in some other condition, or you're a generalist, let me give you a few tips here. Number one is the chances are good that person has a medical problem that is underdiagnosed or undertreated. Number two, and this is, I think, something that you should watch out for, is that patients, when they embark on getting medical treatment, if they have a diagnosis of schizophrenia or bipolar disorder, are less likely to get the basic care that other people would get if they didn't have a mental disorder. Let me translate that to you.
Well, let's get back to that right after the break. I'm Dr. Ogan-Garel. This is Insights in Medicine with InTimeTV with Dr. Peter Weiden, Director of the Psychosis Program at UIC, talking about the general medicine implications. You can send questions to ask at InTimeTV.com. See you shortly.
Once they've outgrown their toddler seat, they're still not ready for adult safety belts alone. 4'9" is the magic number. Until then, kids need a booster seat. Make sure your little pumpkin gets there safely. Visit boosterseat.gov.
Protect yourself from mannequinism. Volunteer. Vote. Stay informed. It's easy to get involved.
Welcome back. I'm Dr. Ogan-Garel. We have a great program underway here, the general medical implications of severe mental illness, with our guest, Dr. Peter Weiden of the University of Illinois, Chicago, professor of psychiatry there. Just before the break, first of all, I had mentioned that this program is interactive. You can send your questions to ask at InTimeTV.com. That's on your screen there, ask, A-S-K, at InTimeTV.com. We look forward to your questions. Dr. Weiden has indicated his willingness to address the wider questions from around the globe. Now, just before the break, we were talking about some of the recommendations to either general practitioners or even specialty physicians who come across patients of theirs who happen to have, and it's not insignificant, severe mental illness. The first recommendation that Dr. Weiden had told us was to recognize that these are likely, there's likely, to be an underreported or
underdiagnosed, undertreated
severe medical condition, or medical condition, let's put it that way. And the second point is that it's likely to be undertreated.
That's coming in. And then you're faced with, okay, now what do I do?
And now what do you do? So tell us about that and what's the quality aspect.
So I mean, I think one just has to sort of almost start from scratch and do an entire evaluation, and don't assume that the person has had proper care or evaluation. These are high-risk patients.
Mm-hmm.
Then the other thing is if it's important to know, and there's some very well-known important studies now on this, that let's say someone with schizophrenia has a heart attack, and there are defined procedures as to how to manage an MI, how to work up an MI, what to do, and what to treat. It winds up that the mortality, the death rate post-MI in schizophrenia is about a third higher than the general population.
Over 30% higher.
30% higher. And that mortality is due not to differences coming in, but because some of the basic management hasn't been done. So they're less likely to get perfusion studies. They're less likely to get aspirin. They're less likely to be put on lipid-lowering medications. So that the take-home message for you and your practice is, I just want to alert you that the chances are going to be higher that if a patient has schizophrenia or severe mental illness, they're not going to get the routine, evidence-based sorts of interventions that other patients will. And so just stay on guard and be alert for that, and maybe think twice with any individual patient to go through a checklist to make sure that you're not missing something basic, because it does seem to happen with a high degree of frequency. And that is, I think, an important take-home point.
So there's a kind of an interesting balance here, that these are complex patients, obviously, as outlined in this article, a complex disease necessitating complex care. But at the same rate, it's important to recognize almost that they have very basic medical problems, and to kind of stand back and say, this is all very complex. Let's say you're not a professional psychiatrist, and that is the case. I mean, I learned in medical school, I learned working with you, that these are complex cases, but the medical issues, though complicated by the schizophrenia, you should approach it almost from the basics.
Absolutely, and part of the reason for the excess mortality in this patient population is that the schizophrenia and mentally ill patients haven't enjoyed the drop in mortality rate from all of the advances in cardiology and prevention that the rest of us have.
Right.
So keep that in mind. I think that your results will be better if you keep that in mind.
I guess one analogy would be like the management of a trauma patient. The management of a trauma patient, you look at the real basics, ABCs, airway, breathing, and circulation. You know, the management of any other patient, you don't start evaluating the airway if they're talking to you and so forth. But in this case, you kind of really have to go to the basics with severe mental illness patients.
Absolutely. That's a very nice analogy. Just think high risk and go through the basics. I like that. I'm going to use that.
Okay. Well, let's go into some of the more specific aspects of psychiatric treatment. Obviously, these patients with severe mental illness are actively treated, and some of the specific aspects of their medications and the general medical implications.
Thank you. And this is, I think, in many ways a challenging area for us, and one where a primary care physician can really help the patient and help the psychiatrist, because there's good news and bad news here. Mm-hmm. As I mentioned, the medicines used to treat schizophrenia and severe mental illness are becoming more effective. They're not perfect, but they're better. Our psychiatric outcomes are better. But there's been a big problem. The big problem is that some of these medications, especially some of the antipsychotic medications, exacerbate two risk factors for cardiac disease. Not every medicine and not in every patient, but these can be very serious increases in risk of two risk factors. One is weight gain and obesity, which of course weight gain and obesity then puts you at higher risk for diabetes and so on, metabolic syndrome. Some of these medicines, it's not uncommon for patients to gain 50 pounds in 6 months, huge amounts of weight gain, putting them at very different obesity risks. And then some of these medications can either cause or exacerbate dyslipidemia, especially triglycerides, so that I've seen triglyceride elevations of several hundred fasting to really put someone in a different level of dyslipidemia risk. So I think it's a good idea for primary care physicians to know that and to know coming in which medicines can do this. There have been some terrific reports and reviews of this about which antipsychotics. The American Diabetes Association in 2004 published on this. There's some guidelines on that. The biggest problems in terms of naming specific antipsychotic medications are clozapine and olanzapine, and then in terms of weight, to a lesser extent, risperidone and quetiapine. Right. So that a patient coming in on one of those medicines or on other medicines who has dyslipidemia or has obesity may have that obesity or dyslipidemia exacerbated or caused by one of these medicines. So in a certain way, for some patients, we're making a bad situation worse.
And some of the newer generation antipsychotics, even those under development, are not solving that problem.
I think that the way to view this, and for those of you, I'm over 50, and if those of you who are watching this are physicians who are my age, you probably remember in your psych rotation that patients who were on psychiatric medicines looked like zombies. They looked Parkinsonized. They shuffled down the hall, and those were the side effects of Parkinsonism. The newer medicines, in many ways, took away, but then caused...
2 words for you. Pop quiz. Ready? Name any funny movie. A drama. Name a mystery. And one more thing. Name the movie your kids saw today in science class.
Know what really matters. Know about your kid's school. And know about your kid. Find out 100 ways to know more, do more.
There's something about you, baby. I can't get enough. There's something about you, baby. I got you looking at me, I'm gonna call you bluff. There's something about you.
The smallest moments can have the biggest impact on a child's life. It takes a man to be a dad.
Listen to smoke before you give it a try.
Only you.
Don't play with matches. Don't play with fire. Cause there's nothing very funny about nothing very nice. Homeless mind. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire.
Only you can prevent wildfires.
Fire.
Mom?
Dad?
How long should I wait for you?
If I'm at soccer practice.
What if something happens? Will you come get me?
There's no reason not to have a plan in case of an emergency.
Should we go to the neighbor's house?
And some extremely good reasons why you should.
Can you tell me?
Talk to your family about what you would do in case of an emergency.
Welcome back. I'm Dr. Rogan Gorel. This is Insights in Medicine on InTimeTV. We were interrupted a little bit just before the last break, so I'll just summarize a little bit and then we'll just pick up again. Dr. Weiden was telling us about the specific increased risks that are attributable to psychiatric medications, and they were increased risk of obesity, weight gain, and the second were various dyslipidemias, particularly
hypertriglyceridemia. It's the triglycerides that can go off the map. So cholesterol, but to a lesser extent, but it's the triglycerides that have been.
So just to pick up from where we were interrupted, tell us a little bit about what are the classic medications that are at risk, and then what you can do about them.
Now, we're talking about the class of medicines that's called antipsychotics against psychosis, indicated for schizophrenia, but antipsychotics are often used for bipolar disorder, manic depression, or treatment-resistant depression. So as a primary care physician, you're going to be seeing patients on these medicines for a variety of indications.
I mean, the prevalence of schizophrenia is 1%.
It's 1%, so that's a lot.
Bipolar is
another 1 or 2%. Probably 3% of the population has a psychotic problem, psychotic disorder. It doesn't mean that 3% are treated with antipsychotics, but we're talking about prevalence of clearly more than 1%. For right or wrong, also, antipsychotics are prescribed for other reasons, which may or may not be a good thing.
Right,
but the point is that these meds are going to be common in a busy practice. You're going to be seeing patients on these medicines. So the main thing I would like to alert people to is that these medicines can cause significant weight gain or significant dyslipidemia. The weight gain is more known. The dyslipidemia is a story that's just coming out now, so that may not be as well known.
Yes.
But that's one of the reasons I'm emphasizing that here, because of course dyslipidemia is something that's going to fall under the range of responsibilities of a primary care physician. They're going to be discussing diet, exercise, or adding a statin, and they may not realize that someone on olanzapine may have a whopping dyslipidemia from the olanzapine.
So the patient can be, as well as the physician, of course, can be doing all the right things, but they'll still have a persistent dyslipidemia.
I've seen fasting lipids go with olanzapine. This is not common, but it's not rare, go from 200 to 450. I mean, we're talking about impressive changes in dyslipidemia. So the good news with that is it is reversible, but of course then the issue is the risks and benefits of what antipsychotic medication to be on.
Well, this raises the obvious question: to what extent, in other words, how can the physician differentiate between dyslipidemia that's intrinsic to the patient and that due to the drug?
This is a big challenge, because if I come in, let's say I'm taking olanzapine, and I come in to the doctor and I have a very high lipid, is that because I have dyslipidemia and it has nothing to do with olanzapine, or was it because I started taking olanzapine? There's no way to answer that question, which is why in psychiatry and in the work that I'm doing and others are doing, we're really emphasizing to psychiatrists the importance of monitoring for weight changes and lipid changes whenever these medicines are changed. Unfortunately, I wish I could tell you that if a psychiatric patient comes into a primary care physician's office that they're going to have good records on that. I would say that would be a hope and a wish, but it may not be the case. Then you're going to have to do some educated guesswork. But I do want people to know that, at least to consider the possibility of drug-induced obesity or dyslipidemia. These are very impressive things that can happen. The only way you can know for sure whether it's the drug or the patient prior to the drug is to get the before drug exposure and after. That's the only way. A primary care doctor can do a lot of good by educating their psychiatric colleagues, by when you make a call saying how important it would have been to get those numbers, and even if you don't have it in that patient, you'd appreciate that moving forward in future patients. Very important information.
Well, this raises another point. Is prescription of statins actually recommended in conjunction with some of these
that's
medications?
Important. That is the research at this point hasn't been done, and clearly if someone has dyslipidemia caused by medicine and you can't get them off that medicine and does not respond to diet and exercise, statin therapy should be used.
But it's not an automatic recommendation.
I would say that the main thing I would advise is to, if you have a patient that does not respond to statins, who's on one of these medicines, to at least consider getting them off the medicine, because then that would have to be done in consultation with the psychiatrist.
Right.
Because when I say get off the medicine, I don't mean discontinue the medicine. I really mean switch to a medicine that might not cause that dyslipidemia. From a technical point of view, the good news is that the weight gain from antipsychotics and the dyslipidemia from antipsychotics are reversible if you can get the patient on another antipsychotic that doesn't cause it. So these side effects are reversible if you can substitute an antipsychotic that doesn't have it. That's a big if, but it's certainly possible, and that's a treatment strategy that should be considered.
So I guess another takeaway is that it's not a done deal, it's not a lost case that every antipsychotic will have this effect on every patient.
Right.
There are genetic factors, physiological factors, which we do not yet know.
Absolutely.
When we achieve the nirvana of personalized medicine, maybe
That would be really nice once we get that.
But to some extent, just like titration or testing of different antihypertensives and different drugs, which primary care doctors are expert in, namely tailoring medicine, that has to be done with the antipsychotics too.
Well, unfortunately, with at this point, and there's some research that maybe this will change, what I say is you can't draw blood and culture the schizococcal organism and do a culture and sensitivity and get back which antipsychotic will work for which patient. So one thing that is a challenge for a primary care provider is that they're not going to be, they shouldn't be comfortable necessarily saying, I know enough about the psychiatric condition of this patient to say you have to switch this medicine.
So you don't select the medicine on the basis of the hyperlipidemia.
No,
although
you don't.
You can be guided by that or
Right.
informed by that, but ultimately antipsychotic medicine is given for the psychosis.
Right. But what a primary care doctor can do, and this is very important, is to educate the patient and the psychiatrist about the risk of not treating the dyslipidemia or the obesity.
Right.
To really give information about the medical aspect of this equation so that there can be an informed decision that takes into account both the psychiatric needs as well as the medical needs. And
So-
that's where this integration is really important.
Yeah, the integration, the communication, and to some extent the primary care physician saying to the psychiatrist, well, we have a real problem here, for example. Are there other alternatives?
Are there other alternatives? And the other thing that I think a primary care physician can know is that not all of these medicines do this, so that there will be other options. It may or may not be appropriate, but at least you're not stuck with this problem in the class of medication.
Well, coming up on another break, I'm Dr. Ogan Gurel. This is Insights in Medicine with InTimeTV. Our distinguished guest, Dr. Peter Weiden. We're discussing the medical implications of severe mental illness. We'll be right back. Stay right there.
My pot of gold, your daddy's little girl, till heaven home.
It's easy to tell if you've had way too many. But what if you've had just one too many? Buzz driving is drunk driving.
Hey guys, thanks for coming.
Are we in trouble?
No, you're not in trouble. I just want to set some ground rules.
Like what?
Well, remember last week when you hit Vinny in the head with the shovel?
I do not recall that.
Of course not. Well, it was pretty graphic. Too graphic for the kids. So I'm going to have to block you.
I got to make this up to you. This is Vinny's watch, and I want you to have it. You deserve it.
Thank you. That's really not necessary.
No. Come here.
Welcome back. I'm Dr. Ogan Gurel, Insights in Medicine, here with our distinguished guest, Professor of Psychiatry at the University of Illinois, Chicago, Dr. Peter Weiden. We're talking about some of the medical implications of antipsychotic drugs and, for example, in particular, the obesity and dyslipidemia and the importance of the communication between the psychiatrist and the general physician in optimizing that. And why don't you tell us a little bit about, to the extent that, are there efforts in the psychiatric community, just as there were efforts to improve the diagnosis of depression among general practitioners, these communication aspects, outreach, I mean, our show is one of them, but we're not going to change the whole world.
Huge efforts in psychiatry. And
Tell us
first of all,
about those.
this has been recognized now within the field of psychiatry as being probably the biggest problem of the treatment of schizophrenia these days, or at least in the top three.
And the biggest problem being the general medical implications.
Yeah, or at least in the top three. I mean, probably the biggest problem in schizophrenia or bipolar is we don't have a cure yet. But within day-to-day practice, this has become elevated. In a funny kind of way, Ogun, the fact that these medicines made a bad situation worse was a wake-up call to the field, so we realized how bad the problem was to begin with, and then these epidemiologic studies came in showing the years of lost life, and our psychiatric results are better, and then we start losing our patients. So there's a lot of effort within public mental health psychiatry, for instance, the state hospital systems. There's an organization of state mental system administrators called NASHPID. It's a long acronym. They have a terrific report on this. So that this has become better and better known within psychiatry. Now the question is, then what do you do about this? And this problem is being addressed on a practitioner level, educating the psychiatric practitioner both about the importance of monitoring, I think, is the key message. Now this is one of these things. It's a little like the 10 Commandments. I can tell you that the 10 Commandments are good, but the problem is implementation.
Yes.
So I can tell you about monitoring, but I've just taken a new job at UIC, and I can tell you that I'm not satisfied with the monitoring in my own program yet. So it's a lot easier said than done, but I can tell you that the overall thrust is to increase monitoring, increase awareness of the situation, and then to develop both behavioral approaches such as diet and exercise, as well as other treatment approaches such as smoking. Do you know, for instance, that psychiatric patients these days smoke 44% of all cigarettes sold in the U.S.? That's quite a figure, because what's happening with smoking is that the general population, smoking rates are going down, down, down. Within psychiatric patients, those smoking rates aren't going down. So we have our work cut out for us for addressing these issues. So I say that the one big change now is that it has become on the radar screen to address smoking, dyslipidemia, health within psychiatry, and that's been
as
a big,
opposed to something that other specialists take care of.
Sweep it under the rug. We pretend it's not a problem. So that's, I think, a very, very forward move, and I think on some level, I think that also communicates to our patients and our patients' families that their lives are valuable, because if we don't, as in psychiatry, if we don't get off our rears and do this sort of thing, on some level, I think it communicates that person's life isn't worth as much as if you didn't have a mental illness.
Just the
whole
psychiatric
stigma
case becomes...
Right, the whole stigma, you know, it's terrible. Schizophrenia is terrible. I mean, these people don't choose to have schizophrenia. There, but for the grace of God, do you or I not have this illness? So these people are misfortunate enough to have a terrible illness. They need help, and I think I know on a personal basis I've changed my attitude towards the medical issues, and I've become much more aggressive dealing with this. So I think that's been a very good thing in the field in terms of changing. The other thing, from a psychopharm point of view, is that when we think about new treatments, new drug treatments, new antipsychotics, there will never be, no antipsychotic will ever cause as much weight gain or dyslipidemia anymore as olanzapine or clozapine. It wouldn't make it to market.
Right.
So all the ones now being developed, just like 10 or 20 years ago, the big breakthrough with antipsychotics 10 or 20 years ago, can we get an antipsychotic that doesn't cause EPS? The answer is yes. We had those antipsychotics.
EPS.
I'm sorry. I forgot I'm talking to a general. EPS is the extrapyramidal symptoms.
Oh, yeah, right.
The Parkinsonism, the slowed down, the shuffling. So that was last generation's job with drug development. The new wave of antipsychotics, now they raise the bar even higher, because now for an antipsychotic to make it to market, to be approved, can't have EPS, and it can't cause weight gain or dyslipidemia to the extent. So that's getting better. So things are getting better.
It's still the concept that looking at the integrative view of the general medicine should remain. I mean,
and I think your point earlier today, I think, was very well put, that while schizophrenia is a complicated illness, or bipolar disorder is a complicated illness, the medical needs are basic, and we're not doing the basic. And the primary care provider, by staying with the basics, can do a lot of good in this.
There's a flip side to that, as you were saying, that with the success of psychiatric medicines, the general medical aspect is coming more to fore, and psychiatrists are grappling with that. There's a flip side, I know from the example of coronary artery disease, that cardiac surgeons, as well as interventional cardiologists and medical cardiologists, 20 years ago focused on essentially saving the life of that patient and opening up the artery. That was the technical challenge, and it was more than just a technical challenge. It was saving their life. The patient's life was in the balance. But as patients have survived and those techniques have gotten better, we've had obviously post-MI depression, we've had pump syndrome and so forth, and cardiologists becoming more aware for the overall quality of life for their patients of the psychiatric aspect.
So with each advance comes a new problem.
Some new things. So we're going to take a break. One of the aspects of Insights in Medicine, our program here on InTimeTV, is specifically to encourage that communication between specialties and to look at medicine from an integrated perspective. And nowhere is that more clear than during our discussion in this hour. We'll be right back. I'm Dr. Ogan Gurel, Dr. Peter Weiden. Look forward to seeing you in a minute.
Family and friends can provide the support you need to reduce your risk of cancer, diabetes, heart disease, and stroke. Eat right and get active.
Impossible. It's never too early to start reading to your kids.
Are you prepared for what awaits you?
There are amazing possibilities when you open a child's mind to reading. Log on to the Library of Congress website and let the journey begin.
Welcome back. I'm Dr. Ogan Gurel. I'm here with Dr. Peter Weiden, Professor of Psychiatry at the University of Illinois, Chicago. We've been coming near the close of our hour, but a very important and very informative discussion on the general medical implications of severe mental illness. As befits your illustrious career, integrating the public health and psychopharmacology on many levels, and we don't have time to talk about all those. But this is really at the nexus of that in terms of improving the health of patients and so forth. One of the things we were talking about just before the break was how, as psychiatric medicines have improved and psychiatric outcomes have improved, the general medical aspects, which paled in comparison to the suicide risk staring in the face of the patient and the psychiatrist, now become more important.
It's lagged behind, and now we've got some catching up to do there.
Well, I wanted to mention one aspect of that. I remember, and I might be dating myself, that when I was in medical school, Clozaril had just come out. And please educate me and our audience, but at that time, Clozaril, correct me if I'm wrong, had to be prescribed with a rigorous monitoring program for, I forget what it was, anemia or liver function tests.
Yeah. Well, Clozaril, you know.
So my point, I guess, is that as we develop the sophistication and understanding and the rising importance of these general medical aspects, to the extent that the FDA can mandate some monitoring associated with these drugs, do you think that might be a solution to the problem?
That's an interesting question, and the issue about mandating monitoring is a very controversial one. I think there's been some, with clozapine, I think it's generally been a success. I think there's some issues about monitoring for pregnancy with the acne drug.
Yeah, exactly. There's that one.
So, it may not be I think it should be considered.
Yeah.
It's
I remember
it's a
it was
great
very
question.
strict for Clozaril.
I think that the way I would think about it for primary care physicians is that if you are a psychiatric patient on these medicines, you are a high-risk patient, just like a patient with diabetes is a high-risk patient.
Yes.
Just like a patient who's had an MI is a high-risk patient. So I think the thinking about monitoring for these patients is that they if you have schizophrenia or bipolar disorder and you're on these psychiatric medicines, you've automatically brought yourself into a high-risk monitoring situation in terms of glucose, lipids, cholesterol, that sort of thing.
And I think one of the aspects is the integrative view of things. And I'll explain that to the extent that a psychiatric patient, like we said at the beginning of this hour, they're less compliant, less like a patient who's not burdened by such illness, pick up the phone, set up that appointment to get the blood test. I want to find out what my triglycerides are tomorrow.
Right, right.
So the mandating of the test
and they don't have as many
is an acknowledgement of those challenges.
Right, and and a thing I would like to actually emphasize, for the most part, psychiatric patients don't do that not because they're lazy,
yeah, of course,
but because they have symptoms. So it's not their fault. And also, they don't have families. Like, I'm on Lipitor. Now, why am I on Lipitor? It could be because I have great insight into my need. No, my wife would kill me if I wasn't on Lipitor. So
support networks.
Yeah, so
yes,
support
exactly.
networks. But well, people with mental illness don't have as many social supports. They're less likely to be married. So the things that you or I might be compliant about because someone's on your tail to do something isn't going to be there. So there are lots of reasons. It's complicated.
Yeah, and then I know that your career, as I mentioned, and the work you've done has been in the public health, psychiatry intersection. We've all heard of the very tragic situation with Virginia Tech and the student, and a lot of us were educated in the concept that patients who are on the medications or who have the diagnosis can't buy guns. So there are different sort of legal aspects. So to some extent, one could stipulate such monitoring. It's not morally equivalent to that, but the point is that when you have that psychiatric diagnosis or been on that with that prescription without going to a stigma, there's a different set of responsibilities that society has and you have that may allow that.
I agree. I think it's a shared responsibility. I think the patient has some responsibility to take their medicine, to get help, to as much as they can.
But they're encumbered.
And they're encumbered, they're burdened. I think we have a responsibility to take that extra step, to meet them halfway or three-quarters way to help them with that. So it's, I think we could be doing better. And the reason I'm here is to say that the primary care physician is not an adjunct anymore. We realize that these illnesses cannot be dealt with without paying real attention to physical well-being, and we need all those advances and the expertise that our medical colleagues can put to the table here.
Well, I think that's a fantastic takeaway that our audience should take, and I'm really glad that you're here, Peter, to tell us about that. But that also raises another point. To the extent that psychiatrists have to talk with a highly fragmented primary care community, these are extremely complex cases, difficult patients, multiple comorbidities. To some extent, is this a lost case? I mean, is it an impossible task?
It's hard. It's difficult, but not impossible.
Okay.
There's been a lot of discussion about this. I think that there's been a consensus that there are ways to reduce those barriers. Maybe physical proximity, that that a psychiatrist practice in a medical suite.
Interesting idea.
Or that a primary care physician go to a clinic, reduce those barriers.
A psychiatric clinic.
Psychiatric clinic.
Half a day a week
right.
or whatever. Yes.
There are economic issues. How do we pay physicians for the work that they do, including the extra time it takes to treat someone with a psychiatric condition? So that these things are addressed. Yeah, and the monitoring concept. So that these are complex problems. They are. There is a greater awareness on a National Institute of Medicine level of putting the psychiatric patient as a disadvantaged patient and needing the extra support and care. So I think that's being recognized on a public health basis. On an individual basis, I would say we can't do everything, but just to be a bit more aware and perhaps work a little bit harder is, I think, a good thing. And you'd be surprised, I think, at how much you can do. I used to sort of say, I can't make any changes in someone with a psych condition. That's not true. You can make tremendous improvements.
Well, Dr. Weiden, that was a great way to summarize an extremely important hour. Really appreciate your time, Peter. And again, this is Insights in Medicine on InTimeTV. See you next week.